हेलो सर,
या
प्लीज स्टार्ट।
अमोल तो है नहीं. ओके. सो टुडे आई थिंक आई विल ओनली स्टार्ट. और विनायक सर, यू वांट टू स्टार्ट?
No, no,
यू
sir,
कैन.
you can start. No
नहीं,
problem.
यू कैन स्टार्ट एंड देन आई विल स्पीक. नो प्रॉब्लम.
Welcome all to the third casebook program. This is the third episode of our monthly casebook live. So it's an interaction with the PG students, a case-based discussion, and every time we have different case and different expert in the eminent faculties are there, and then we come and discuss so many things, and interesting facts of the case are revealed. This is a good project from Ram Gopal sir and Bhavesh Mithya sir under Maha AP program. Every month we have different cases are there. So this time over to you, sir, for beginning, and then I will introduce the faculties.
Okay. Good evening, friends. Welcome all. Welcome to the Casebook Live. As already Vinayak sir has told you about the Casebook Live, this is a concept where no one knows anything. These are the actual case handled by the pediatrician, and today even we don't know what is in sir's kitty. So welcome all. Welcome today's experts, Dr. Sagar Lad and Dr. Nikhil Pathak, and today's PG student, Dr. Saraswati and Dr. Madhura, and their mentor, Dr. Sushma Save. I think she would be joining little bit late. Without delaying much, I will just request Dr. Patki to start with the cases.
Yes.
And introduce today's faculty.
So my screen is visible.
Yes, sir.
Yes. So today we have fortunate to have two pediatric intensivists. One is Dr. Sagar Lad. He's a pediatric intensivist from Jahangir Hospital and Sahyadri Hospital, Pune. And Dr. Nikhil Pathak is pediatric intensivist and enthusiastic pediatrician from Aurangabad. We have two PG students, Dr. Sarabati Babu and Madhura Kaviskar, under the mentorship of Dr. Sushma Save. So without much wasting, I will start the case. So this is a 13-year female, only child of a second-degree consensual marriage. Complained with fatigue, poor appetite, nausea, gradual weight loss for almost last 6 months. From 39 kg, she has come to 30 kg. History of fever, mild grade on and off, lasting for 2 to 3 days, thrice in last 6 months. No history of joint pain, no history of rash, jaundice, or cough. Consulted general physicians mainly and then pediatricians. Investigated 3 to 4 times. And just I will reveal the investigations. So when it was 90, the mild fever was there, mild no tachypnea. Heart rate was slightly higher, 152. On room air saturation was 94. She has mild pallor was there, no clubbing. Cervical nodes were there, but discrete, non-tender, 1 to 2 centimeter. She has no murmur, no added sounds. Liver was 2 centimeter. Spleen was just palpable. SMR staging was pre-adolescent. So here are the problems: 13-year female with fatigue, poor appetite, weight loss, on and off fever, mild pallor, cervical nodes, tachycardia. And let me know, go to our PG students first. So keep your camera on and start. What are the different possibilities you think in this case and how we should proceed? Yes, PG students.
So since the presentation is more like a chronic presentation, because the complaint was almost for 6 months, so fatigue, poor appetite, and weight loss, it could be the one possibility could be malignancy also. And malignancy and this presentation was also like on and off fever with mild pallor, cervical lymph node, and tachycardia. So there is some underlying, it could be because of underlying anemia also. So some malignancy with anemia.
How frequently you have seen malignancy presenting like this?
Another possibility could be TB also.
So more of infectious cause. Anything else? Anything else you think?
It could be autoimmune condition for a 13-year-old.
Okay. Anything else? Yes. So we have investigated this case. The investigation shows this is something. A lot of investigations are here because she has been investigated thoroughly because of a lot of things. Just I will want to highlight these things. So she had anemia, leukopenia, then platelets 1,65,000, ESR 35. But random sugar was slightly on lower side. creat was 1. This pH is 7.46, PCO2 of 41, bicarb of 29. Urine pH was 5.5, specific gravity was low. 1 ketone was there, protein 2 plus, hyponatremia, hypokalemia, calcium low, alkaline phosphate is 345, vitamin D low, serum proteins were low, and TSH, this you can see T3, T4 are free T4 is low, and free TSH is also within the normal limit. So I want your things about how do you see these investigations. So don't repeat the investigations now. Let me know what you are thinking from in terms from these investigations under the background of loss of weight, fatigue, poor appetite, all these things. Go one by one. Start from CBC. How do you interpret?
More like a bicytopenia picture is there. So two cell lines.
Okay. Yes. Then coming to sugar and creatinine.
Creatinine for 13-year-old child is good. But
Okay. So how many?
borderline.
How do you interpret
Borderline.
this? Okay. Okay. Yes. How do you interpret this blood gas? What is your interpretation on blood gas?
It's more like a metabolic alkalosis picture is there.
Metabolic alkalosis. Okay. Coming to sodium, potassium.
Sodium is hyponatremia and potassium is like
Okay.
lower side but borderline lower side.
Okay.
Calcium and vitamin D are low.
Low.
Alkaline phosphatase is high.
So what TSH about what is your take on thyroid profile?
TSH is normal with a normal limit.
TSH is normal and T3 and T4 are low. So how will you interpret all these investigations?
Hypothyroid. Like
Just
subclinical.
go one by one. Don't jump directly, because before going to experts, I would like your opinion on these things. So what is happening? So many things are happening in this case. So what do you think? What is happening? Why this child has metabolic alkalosis? Girl has. Can you just summarize what is happening in this case? So yes, it is a blood system is affected, 2 series, creatinine is liver is affected, kidney
It is
is
more like a
affected.
renal involvement predominantly.
Yes, renal, hepatic,
It is
thyroid.
more like a renal pathology.
Yes, anything else? And alkalosis is there. Yes. So what do you think? The serum creat 1 is normal for this age, for her stature of
It
the
is on higher
It is
side.
higher side.
higher side. Okay. So what overall what do you think before going to experts?
So multi-system involvement.
Metabolic alkalosis.
So it is a more like a metabolic problem, isn't it?
Yes.
So with this, I would like to go to expert now. First, we'll go to Dr. Sagar and then we'll come to Dr. Nikhil. So Dr. Sagar, what do you think? What is happening to this case?
Now, if you see the history-wise, no, the child has got a fatigue and the weakness, and it is going on since a long time. So you can indicate it is more of a chronic disease, not an acute disease. There is a weight loss. Weight loss indicate there is some sort of either infection, inflammation, or maybe a metabolic, or maybe you can say leukemia or lymphoma, that form of a thing. Even if you see the X-ray wise, there is of a cardiomegaly, and predominantly the heart is seeing of a more of the left ventricular type of the heart.
X-ray will come to it later. On these investigations, what do you think? Yes. Sagar, you are not audible.
Disconnected. He got disconnected, I think.
Okay, Nikhil, you can continue meanwhile.
So let us think. So firstly, it's a long process. So first let us think whether it is an infection or inflammation or any chronic diseases.
Yes.
So if we are thinking of an infection, we need to see which infections will go for this. So when you're forming this thing. So when you take the history, you will think that which infections will last for around about 6 months. So tuberculosis, brucellosis, sometimes subtle, may present for such a long period. So they have these recurrent episodes. But another thing what we will now think is inflammation or metabolic thing. So once you see the investigations, you will see that all the systems are affected. The hematological system is affected, the urine. So even this urine report, if you see, everything is affected. You have ketones, which is positive. You have proteinuria. We have not quantified the proteinuria, whether it is a microalbuminic or a macroalbuminic. But you see there is a proteinuria, there is a renal involvement. 1 creat is also significant for this child.
Yes.
Even if you see the sodium is low. So that
Yes.
means there is a sodium loss from the body. And again, it might be correlated with the renal involvement. So
Yes.
what I feel is it's more like a metabolic disease, which is going on, lingering on since last 6 to 7 months. And still, I will keep some chronic infections in mind. I will keep in mind whether even the vitamin D low points towards a renal pathology. Something is involved in the renal involvement is still there.
Yes.
So overall, the picture which I get from this, it would be a renal metabolic disease,
Yes.
primarily from this thing. And
Okay.
because it's a 6 months thing with fever, I will keep in mind some
Your,
involvement.
Nikhil, your take on thyroid profile.
Thyroid. So again, free thyroid. Why we do a free thyroid? Initially, these were. So free thyroid gives you the exact thyroid. Though the TSH is not raised, I will keep this in mind as one of the things which is significant. The free thyroid should not have been low. It should have been on a little bit higher side to get a normal TSH. So again, that thing is so. Overall, it looks like something metabolic involvement, which is involving the renal involvement. And I will also keep some, the another point which we have missed is the tachycardia.
Yes. Yes.
Why the child is having the anemia 10.2 HB will not cause. So anemia is not causing tachycardia.
Yes.
So from again, some cardiovascular involvement is there. The cause for tachycardia we have to see.
Okay, thank you. So just we'll proceed now. So at this point, just go to PG student first. At this point, any other investigation other than this you want to do? Unmute yourself. PGs. Yes. Anything you want to extra at this stage?
For cardiomegaly and tachycardia, we could do it
2-day.
Okay, anything else? Routine common investigations?
USG, KUB, UPC.
So we did abdominal USG for this girl. And what we found, minimal right pleural effusion, minimal ascites, hepatomegaly was there. And because of nodes and what we were really worried about what is happening to this girl. So we did HRCT chest also, which revealed 2 para-aortic lymph nodes, minimal bronchial thickening and few plugging. Dr. Sagar, at this stage, what do you think? What is happening to this? With the background of, yes.
Yeah, the thing is that seeing a kidney, probably kidney is losing the protein. So that probably that might be a hypoproteinemia. Albumin is also on the lower side. And that might be the reason he has got the some form of effusion, some form of the ascites, which is again a minimum in the nature. So this 2 investigation has added that there is some fluid collection in the abdomen and in the lung. Secondly, also there is some few para-aortic node which are again seen in the HRCT. So in the investigation point of view, I would like to add LDH and the uric acid also in the initial part to rule out like a lymphoma and the leukemia, because all the factor might be involved.
Okay.
So
what about Nikhil? What is your take upon lymph nodes? Para-aortic lymph nodes, some bronchial.
Now we have done an HRCT. The para-aortic lymph nodes, they have not mentioned that what is the size, whether they are aggregated, they are matted, there is central caseous necrosis. These things would have pointed out to some. A few para-aortic lymph nodes means these are non-specific. Means at present, I won't consider it as non-specific, but non-indicative. The other thing I would point out, it's a polyserositis. There is a minimal ascites, there is a minimal pleural effusion, and there is no consolidation or something which is seen. So it doesn't look like an infective thing. again, it's a polyserositis, which is pointing out with these investigations.
And again, one more point that the child being a 12-year-old and a girl, so think of more of a vasculitis point of view also. That can be like SLE or the systemic onset
SLE.
JRA. Yeah,
Okay.
so that can be a one possibility.
So here we are dealing with something, lot of investigations have still not revealed us. So any other investigations, PGs at this stage you want to go?
SLE, ANA levels we can.
Okay. Before that,
UPCR also we can do because albumin is getting lost.
so we did sputum for AFB, induced sputum aspirate, CBNAT, and interferon gamma release assay was positive. So what next? We have some indication that there is, it is not infected, but the child has come in. The child has come in contact with tuberculosis. Just please unmute yourself. Some noise is coming. Rest audience. Yes.
We'll go for
Just
FNSC of
Pallavi madam, if somebody is unmute, then mute them.
Doing, sir. Yes, doing the
Rest other. Okay. Yes, Pijis, how will you go about this?
We need a tissue
diagnosis.
diagnosis. So we'll go ahead with FNSC or lymph node biopsy.
Okay, FNSC was not possible. Will you start AKT for this girl?
So
Is
just
there any
being,
Yes, experts.
no, I don't think so. Initially, we should start on the AKT to being considering just interferon gamma assays positive doesn't mean that the child has got a tuberculosis. If you
Yes.
get some sputum positive or CBNAT positive, definitely I will think of, but
Okay.
I will not go ahead. But if you get a tissue diagnosis, like if you get a lymph node biopsy, then probably we can think of, but not now.
Relatives were not willing for lymph node biopsy, and in fact, the para-aortic nodes were very tricky to
Difficult. Yes.
difficult to hit. So, Nikhil, what is your opinion about starting
Again,
AKT?
no, we will not. So now the newer guidelines are we have to prove a tuberculosis diagnosis only with a tissue diagnosis.
Yes.
So sputum was negative, induced sputum was negative. Interferon gamma is just like a Montux. It may be positive with multiple kids, and we don't take it as significant. So for me, this thing will rule out tuberculosis. For what we are thinking, a very chronic infection, the first thing in Indian scenario which comes into mind is that it is not tuberculosis because we don't have a tissue diagnosis. So we will just wait and observe.
Okay, so this child, we counsel them. They said we'll put on daily just intake output chart. What other things? Just we told them that these are other things what we need to do, as you said about lymph node biopsy and tissue diagnosis and all that. They said okay, they will follow the case and they will come to me every 8 days. So this was the thing. But what has happened after 2 weeks? Just let's see. So 2 weeks that she had again one episode of 2 to 3 days fever, which was followed by chest pain and breathlessness for 1 day. Then she had altered sensorium since morning. There are no seizures. She was more sick looking, was more pale. If you see the GCS is 10, she was come with peripheries are cold, clammy, peripheral pulses are feeble, heart rate increase, BP has dropped to 78/42, respiratory rate 34, SpO2 was 88 on room air, chest air entry was equal, fine rails were there on both lung fields. She has tachycardia, some gallop was there. And she had a liver of 3 centimeter now, spleen of 1 centimeter, and tenderness in right subcostal region. So this is some chronic disease which has now led with again history of fever, and she has landed in this. So what is your physiological PG students? What is happening to this girl?
into failure.
Cardiac failure.
Okay.
Liver enlargement is there with tachycardia with shock.
So it is more like a shock along the pulmonary congestion feature is also there. So it is like CCF.
No. What kind of shock are it? Septic shock, hypovolemic shock? Because shock.
It is more like cardiogenic shock.
Cardiogenic shock.
More cardiogenic shock. It is okay. This is hypotensive or normotensive shock?
Hypotensive.
Okay. So what you will want at this stage?
for pulmonary edema, we'll have to get Lasix.
Before that, we have to stabilize BP with.
Okay. Before that, just before.
And if it is
Okay. Yes. Before going to the
the sensory part, we have to.
further investigations, a view from experts. First from Sagar, then from Nikhil.
Now, see, management point of view, now this child has got a cardiogenic shock. Is a tachycardic, her BP is low, so it is a hypotensive short of a shock, and has got a Krebs also, has got a hepatomegaly. So clinical evidence, the child has got a cardiogenic shock, which is a hypotensive. So we need to do A, B, C as an initial part of a management. We will not be in a hurry to give a diuretics or Lasix because the hypotension will get worse. So I will put on the child has got
okay, Sagar, we'll come to it later. What Peaches, what investigations you want at this stage? Then we'll come to Nikhil for further. So at bedside, what do you want for this girl? So impression you told me about this is maybe more likely to be a cardiogenic hypotensive shock. So this is the X-ray. First bedside investigation. So can you read this X-ray? What is happening?
Congestion.
Okay. Yes. Anything else? There is no cardiomegaly, but
it is not there.
Anything else you want to know at this stage in the ICU or ER? Management point of view, as Sagar sir was saying about managing fluids and all that. What exactly you want to know at this stage? What? Yes. Anything else you want to know? Investigations at this stage.
CBC, since pallor has increased, we'll have to see the hemoglobin also.
Your voice is cutting. Be near to the computer. Don't move.
Since pallor has increased, we'll have to see the hemoglobin.
Okay.
And
before that, what do you want exactly? First
ECG doc, we can go for it.
Okay. So these are the investigations. Now interpret the investigations.
It is more like a pancytopenia now. So previously platelet was normal. Now platelet has also fallen to 36,000.
Yes.
And then ABG
what is ABG?
Acidosis picture is there.
No. What kind of acidosis? You have to be very clear when you discuss about it.
Metabolic acidosis. Eye anion gap metabolic acidosis.
Yes. Other things, what other things are happening now?
Creatinine has increased.
And BU and creat is also, both are elevated.
Yes.
And lactate, CRP is also elevated. And otherwise electrolytes has normalized. Previously sodium of 120 something, and now it has improved. And bili is on higher side, which is more like indirect bili only.
Yes.
And SGOT, SGPT has also elevated. So it is more like because of shock, there is other system involvement is also like renal and liver. So because of that, other parameters have also elevated, renal parameters and liver parameters. With metabolic eye anion gap metabolic acidosis.
Anything else? Nikhil, what is your take on these investigations?
So we see again, the child is in shock. First thing is there is a hypotensive shock. The hypotension itself will cause multiple abnormalities in the investigation. So your metabolic acidosis, it can be explained because of the, even with the lactate increase, it is lactic acidosis, which will explain that it might be because of the shock. There is an end organ problem. So if you see there is a perfusion injuries to the kidney, the creat, which was baseline as 1, has jumped to 1.5, and LFTs, which were normal initially, have also increased. So what I would say initially with this picture, it would be a shock which is causing a multi-organ involvement. So it is a metabolic acidosis, lactic acidosis is there.
So now how will you?
Sir, your voice is breaking.
Yes. How much fluid you will give? Which inotropes? Whether you will intubate this child? Whether you will ventilate this child? So these are the.
So since this is a cardiogenic shock, we start 5 to 10 ml per kg of bolus, and we'll give a slow bolus over 30 minutes to 1 hour. And after that, we'll watch
before that, if
airway breathing circulation.
Yeah.
Okay. So what you will do? What investigations you want at this stage? Anything extra you want? So just we did a point of care ultrasound here. So what is happening to this point of care ultrasound here? So this is a lung
Contractibility is not.
This is lung USG. This is a IVC. This is a 4-chamber apical view and 4-chamber apical view with Doppler. So can you interpret these 4 images? Because now the concept of managing shock is changed. Now we have to manage with point of care ultrasound. And we have now evidence key. So these 4 evidences are there. So what they tell you, what is this that is exactly happening to this girl? Because your inotrope management, your fluid, everything is based on what is the lung, that is what is the IVC that is
Collapsibility.
Yes. So what do you think in this case? What are these lines are happening here? Can you interpret? Have you seen this? Yes, point of care ultrasound before?
No.
Okay. First we'll go to Sagar and then we'll come to Nikhil. Yes, Dr. Sagar.
Yeah, so if you see the cardiac chamber looks dilated, and by
First,
verbal.
Sagar, tell us about lung USG.
Now on the lung USG, you can see it doesn't look like a normal lung ultrasound. Yeah, it looks like a barcode sign. There are A and the B lines, so you can see there is no A line as visible. So it looks like more of a fluid collection in the lung. If you go on. If you go the IVC looks the full. As the child is spontaneously breathing, you need to calculate the collapsibility index of the child. But it looks like a full, and it's not much variation during inspiration and the expiration. So it looks like a fluid overloaded IVC. And if you go to the heart, you can see the chambers are both RV, LA, LV are dilated, and the contractibility and eyeballing doesn't look that way good. So looks like a little bit of a less contractibility in the heart.
In the Doppler?
Doppler, you can
color
see
Doppler?
Color Doppler. I think that is on the more of a regurgitant lesion is seen. More of, I think we should put on the Doppler waves and see whether there is a more of a chamber dilatation can cause the mitral regurgitation.
Yes, so I agree with the severe. It was severe biventricular dysfunction was there. Ejection fraction was only 15%. Moderate MR, mild TR, moderate PH was there. It was dilated IVC, and there was coronaries were normal. So Nikhil, what is your take on this whole picture?
So again, it proves that one more system is involved. Your hematological system was involved, your renal system is involved, and this again points towards the myocardial inflammation. So ejection fraction is decreased and the child is in CCF.
Yes.
So the shock would be again, as Madhura and her colleague has already told us, that it looks like a cardiogenic shock and the child is in cardiogenic shock.
Okay, so now pages, how much fluid you will give and which inotropes you will use now, with what dose?
5 to 10 ml per kg.
Slowly
Okay.
over 1 hour.
Then now with this so much dilated IVC, you will give fluid.
For the inotrope to act also, there should be some intravascular volume. So
there is full intravascular volume is full.
And for inotropes, you could go with dobutamine.
Which because his blood pressure is 78. So which inotropes you will use, because that will decide fate of the child.
Since there is hypotension, so it is more like a cold with wet shock. So since there is a hypotension, we'll go for epinephrine also. Once the BP has been stabilized, then we can go for milrinone or other ligocimab.
Okay. Will you ventilate this child or not?
Yes, since the child is in shock, but
decompensated.
This GCS
refractory shock, then we have to.
GCS 10, will you intubate? We'll take experts' opinion, both Sagar and Nikhil, one line. Will you intubate this child or not?
Yeah, I think any cardiogenic shock needs early intubation. Even if the child is in the HFNC or on the support, you need to continue that support, and with that HFNC, you intubate the child. Early intubation is the crux in the cardiogenic shock.
Okay, Nikhil, at this stage?
We do not want the child to deteriorate suddenly. The GCS is borderline. So what is happening is the GCS is 10. at 8 GCS or below 8 GCS, we have to definitely intubate. But as sir has said that you don't want that all the things, you are managing shock, it is more useful to maintain the airway. So elective intubation with managing a shock, and once the shock has recovered, we can extubate early.
Okay.
But
Okay.
we can just observe, look at the thing.
Okay. Now this new surprise has come. We send investigation. This has come like D-dimer 10,000, ferritin 5,000, LDH 1,800, rat negative, NS negative, dengue IgM positive, weekly positive, COVID IgM negative, COVID IgG positive, well flix 1 in 60, 1 in 60, borderline. Interpretation. PGs.
Ferritin is high because some inflammation is happening there. So because of the ferritin is high. And LDH is high, it could be because of cardiac involvement also. It is cardiac marker as well.
Yes.
D-dimer on higher side. So that is.
So can you explain this on dengue? Can dengue present like this? Here COVID IgG is also positive, dengue is also positive, well flix also is border positive. So which investigations you will give as a importance at this stage? Because this is called as an acute inflammatory condition. No? Everything is increased. CRP is increased, D-dimer is increased, ferritin is increased.
So like MASC just like this.
Okay, so we'll go ahead. So this will because of what is concept is known as a physiological difficult airway. That's what message I want to give. Whenever child comes with shock, so as our both experts said, he needs intubation, but before that you need to stabilize the child. So try to start with some inotropes, try to give HFNC, give some time, because in a hurriedly, as they really pointed out correctly, that never try to intubating hurriedly, because that is the time you are likely to have crashing of the child. Never start Lasix before starting inotropes and adrenaline. So we started with slow dose adrenaline. We started it, and we simultaneously then we started with dobutamine and milrinone. We are given meropenem because of, as you said, some of like MIC kind of picture was there. So solumedrol was started with 2 milligram per kg, IV gamma was given, and LMW was started. So next day, inotropes continued, taper to his blood pressure improved within 10 to 12 hours. Blood pressure is normal now. Tachypnea is slightly less. Heart rate is also dropped down. Now see the liver size as same but tender. Now things are important here is now from metabolic acidosis, the child is different in a compensated. This is compensated metabolic acidosis now with 7.42 PCO2 45. Here sodium has increased now and potassium has 2.31. So we started with double dose of potassium. So what is your take? Is this thing child is improving? Child is not improving? What are the things what will decide that the child is improving or not? Pages.
Child is improving, like the shock has
Resolved and O2 requirement that
has
also
decreased.
decreased.
Tachycardia has decreased.
Yes.
Lactate has also
What two important markers are here is lactate has dropped down and child is passing urine, and general condition is also better. Okay. But what has happened? Of day 3, child has suddenly started difficulty in moving limbs. Child has developed motor weakness, both upper limb, lower limb. Shallow and very labored respiration. GCS has gone down 322, so it is 7 now. Again escalated to 20. FiO2 is this is now respiratory rate of 18, SpO2 is 91, blood pressure is okay, output is there. CNS is hypotonia, areflexia, and plantar flexus. Now at the background of the child with congestive cardiac failure, high D-dimer, high ferritin was okay, and now suddenly he has on day 3 he has developed motor weakness, altered sensorium, and hypotonia, areflexia. So what has gone wrong now with this child? What is your approach at this stage, Pages?
It is more like because of infection, there must be some antigen antibody response. So because of that, CNS involvement.
Are you thinking in terms of stroke?
No.
Because
of hypotonia, areflexia.
Yes. So what clinically you are thinking at this stage? And what investigations you will order at this stage? Because the child has shock has improved, but child has landed in some other problem, isn't it?
Child also had hypokalemia.
So what investigations you will order at this stage?
Hypokalemic
Serum
paralysis
electrolytes.
also.
Will you go for imaging MRI at this stage?
We'll
We'll
let the child
repeat
stay with
potassium
the
once,
potassium levels.
because
Okay.
last potassium was also
And
2.3.
GCS has also dropped less than 8.
Oh, GCS is dropped, no? That's why I'm
Yeah.
asking. Will you ship this child for MRI at this stage or not? If you
No,
want
we'll
to.
intubate the
We
child.
will first stabilize the child, intubate the child for
Okay,
GCS
okay,
less than
okay.
8.
Okay, experts, just a quick comment from you. Anything
I
at
would,
this stage, okay, what they are saying is, okay, some electrolyte disturbance they are saying, but anything
yeah.
can go wrong with this child.
So we will first intubate the child, again stabilize. What you can see is the output has increased from 2 ml per kg per hour to 3.5 ml per kg hour. And mostly
Yes.
we are using diuretics.
Yes.
And potassium being on lower side with diuretics, it must have one of the reasons for sudden deterioration is electrolyte disturbances.
Yes.
So we need to keep that in mind. And as they have said, we will look out for the electrolyte which has caused this acute deterioration. Calcium, we will also see whether there is a calcium hypocalcemia which is presenting. Hypomagnesemia may present in the same pattern, hypotonia, areflexia, and plantar flexus. So what I will do is, because the child was stable and this is a new acute neurological thing which has developed, and we are still dealing with a non-infective cause accordingly. So let us look at first the electrolytes and then move further.
Okay, so this is something what we have discussed now, and let's see, this is something has happened. So now it is from respiratory plus metabolic acidosis. pH is from 7.28, PCO2 is 48. So can you interpret this, why these things are happening, Bridges? What is happening to the blood gas?
So now if you
pH
see
has
that
more towards acid.
Yes.
it's a respiratory.
Yeah, respiratory component is
acids.
there due to like the breathing pattern.
Shallow breathing, because of shallow breathing, there is PCO2 retention is there. So because
Okay,
of
as
that,
you said,
acid.
potassium is 1.71. At this stage, any investigation you want? Because EC. Okay. How you see this is, let's see what is the EC.
It's not that. Hypokalemia picture is there because of appearance of U wave is there.
Yes.
P wave is not that much prominent. So there is flattening of P wave is also there.
Okay, so flat T waves and U waves are appeared. What is your take on magnesium?
Magnesium is less than. Magnesium is a normal range. It is 1.5 to 2. So that would be
slightly on maybe on lower side. Okay, at this stage, MRI also we did after stabilizing this child. So how will you manage this case now?
Since there is ECG changes is also there with hypokalemia. Initially, we'll go for potassium stat correction.
How will you do potassium correction?
We give
0.5 to 1 milliequivalent per kg.
Okay, so let's see how things have happened. So treated with 0.5 milliequivalent over 1 hour, then put on 4 milliequivalents KCl. Aldactane was added. GCS improved over next 2 hours. Respiration become normal. Motor weakness is improved. HFNC tapered. Then now that day 4, the potassium is now 2.8. So what you will do in any this kind of cases? Is there any role of magnesium sulfate for this?
So it is a refractory hypocalcemia, then hypokalemia, then we'll go for.
So don't you think this is refractory?
Yeah. Then we'll go for magnesium sulfate.
Is it it is a diseased potassium or it is iatrogenic? What is your take?
It can be iatrogenic due to laches. So that's why we have added aldactone.
Yes.
But it could be.
So it is a yes. Dr. Sagar and Nikhil, your take on this potassium business? What?
I think the child initially from beginning has got a loss of the potassium from the urine. It is some tubulopathy. And top of that, the Lasix has been used as an infusion. So both has contributed to the low potassium. So it is both way, not only the disease plus iatrogenic also. and that need aggressive correction.
Okay. Will you at this stage give Maxel to this girl or not?
Yeah, I think he need to give Maxel because calcium actually was not mentioned, but obviously the calcium is also going to be low. And usually both should be corrected with calcium, magnesium, and the potassium. All three needs to be correction.
Nikhil?
Yes, so it looks like something which is channelopathy, which has affected the kidney was affected with some channelopathy, which is causing the loss. We had seen that renal involvement was there. There was proteinuria was present. And with these, when we treated with diuretics, this must have caused an excessive loss of all the anions. So there might be a loss of magnesium also, calcium also, and potassium. We have documented that there is a loss. So replacing all of them would be important. What I would like to point out is here now what we are treating. So what I would say it looks like a macrophage activation syndrome. A macrophage activation syndrome, because I won't say it's an HLH or this thing, but it looks like there was an underlying primary disease on which secondarily there is a macrophage activation syndrome. There is a cell line depression, there is transaminitis, there is myocarditis. So all systems are involved. So even the renal involvement is known to occur with these syndromes. And on top of that, using the drug-induced hypokalemia has present.
Okay. Now, PG students, what is your take on sodium? Before proceeding to the case, you are seeing this sodium for a long time now. So it was, what is your take? Last 4 days or maybe before this admission, you are seeing this sodium. What is your opinion on that?
Initially, it was
Initially it was on the
129,
lower side.
then it came 140 something, and now it is 131. 131.
131 is normal?
No, 135 to 140 will, 45 will take
lower
us
side,
range, but it is on
borderline
mildly
low.
lower side.
Okay. So there is some kind of hyponatremia.
Hyponatremia also.
So now day 5, child has again had high pain. It has come now 103. Now a child has neck pain. Difficulty in neck movement. Child was not allowing to touch. There was we find that is marked neck stiffness was there. So this is something now MRI is normal, but that was 2 days prior. Now child has a very high grade fever. Platelets had come to 63,000. ES are high. CRP D dimer has come down to 2,100. Ferritin 1,600. Sodium 136, potassium again 2.6, blood culture is no. So why this child has developed now fever and neck pain or neck rigidity kind of thing? How will you proceed?
Something hospital acquired infection. We can think.
Okay. Why neck pain then? Fever explainable. Yes, you can.
Yeah.
But hospital acquired infection, see, CRP has come down, procal has come down.
Yeah, everything is decreased.
Then why this high grade fever and neck rigidity pain is? This is really troubling, na? And day 5, so the child is not at all on smooth track, na? Something is happening every day for this girl. So how will you see this new onset fever with neck pain and difficulty in neck movement?
Neck rigidity and fever points towards meningitis.
Okay, you are anyway, what is happening? You are giving meropenem, you are giving steroids.
Yes.
But okay, but what do you think? What is happening to this girl? What investigations you want now?
CT if there is.
Okay, MRI kiya na 2 days back. Again you want CT.
Abhi there is sudden deterioration.
Okay. We'll ask expert what they will think. Sagar?
Now, see, the fever is getting on, so we need to see whether the disease activity is improved. Like if it is a recurring again, even if it is like macrophage activation syndrome, if it's settling down and it's restarted fever again, we need to see that macrophage is that is hemophagocytic again start coming into the picture. That is one possibility. Second possibility, the child might be getting a VAP or central line associated infection. Even if the day 1 the count is normal, has got only one fever spike, so it might take a time to get the count to rise. So if we get a fever, we need to rule out all hospital acquired infection like a VAP or the CLABSI or the COTI.
Nikhil?
I completely agree with Sagar sir, because there are multiple lines there. So I would just like to rule out some hospital acquired infection first. And again, macrophage. So I would like to repeat the serum ferritin. I would like to see what is the cardiac output at present. Has it improved? because in spite of giving steroids, you are having fever, which is not a good sign because steroid itself should have caused the
What
fever to
action
go
you
off.
will take? PGs at this stage. First from PGs one line, then from Nikhil and Sagar. Yes. Yes, we send all cultures and all as expected.
So we'll try to remove those if we are thinking of more like a hospital acquired.
We'll send
Okay.
the cultures from the lines.
So will you go for CSF at this stage?
For only one fever spike.
Okay. So what we did, we just removed the lines, central line removed, catheter removed, fever spike settled, CRPs. Anyway, we were not thinking, as both our experts agree with that. We were not looking at infection kind of thing. So general condition improved, inotropes tapered, accepting orally now, IV fluid stopped, oral Kesol, and this was started. So now day 8 has come. Day 8, what has happened? CRP has come down. Sodium is again dropped, 129. Potassium is 3. Creat has dropped. SGOT, SGPT has dropped from thousands to hundreds now. Now see what has happened to the blood gas. Blood gas has from alkalosis, acidosis, compensatory acidosis. Now it has come to metabolic and respiratory alkalosis. So what is your take on this at this stage? Vijis.
So we again have metabolic alkalosis with hypokalemia, hyponatremia. So
Yes.
More like renal.
yeah, renal
Renal
channelopathy
Yes.
is thing we'll have to keep in mind.
Okay.
Then the blood picture may there is persistent bicytopenia picture is there. Pancytopenia picture is there.
Now pancytopenia is not there. No? Platelets are improving.
95, it has improved from beginning, but
Yes,
platelet
yes.
is on still.
Because CRP is come up. Yes. At this stage, opinion from Dr. Sagar and Nikhil. One line.
I think the bicarb is on the higher side. The whether a child is still on the lastics, because
No.
usually diuretic, so because diuretics can cause more of a bicarb level.
Yes.
So whether after a recovery, again the renal problem is still persisting, that might be the explanation for this.
Yes. Sagar,
Nikhil? So what I would say is the child has returned to the baseline. So what it was there 2 weeks before, there was metabolic alkalosis with mild hypokalemia, with some disturbances in the platelets and the TLCs. So what I would say, he has stabilized and we have come back to the chronic disease which was there. So acute thing has got over and we are back to the chronic disease.
So we have sailed from the crisis and we have come back again to the normal on day now. And see, as we are expecting, this is the improvement in the cardiac contractility at 4-chamber view. This contractility LV function has been improved 55 to 60%. Both ventricles are now, but there is still moderate pH is there. No fever now, no other complaints of inotropes. Just will go ahead. Now patient is stable on day 9. Here now, for his patient on oral protocol, and now in day child has required only 600 gram in child has gained in last few days. So this is now child SB has CBC has come to normal, but still low count is there. CRP is normal now. So in summary, now this child has chronic fatigue, weight loss, persistent hypokalemia, persistent ESR, leukopenia, acute myocarditis, and MIC like picture was there. We don't know what was the reason for that sudden deterioration. So are you happy with this PGs? What are you happy with this girl now?
What is the cause for persistent hypokalemia? We have to rule out the etiology first.
Yes. So what investigations you order now? More problem of a sodium as well as a potassium.
Yeah.
So both the things are because it was hyponatremia also and hypokalemia also. Okay, other series, weight loss and all that, it is okay because child has come from some kind of myocarditis and MIC kind of picture. But what was more bothersome is this child has almost more. So what do you think? Hyponatremia, this child running for long time, then hypokalemia. What investigations you want to order at this stage?
We can go for urinary sodium and urinary potassium to look for any urinary loss.
Urinary
Okay.
chloride.
And
Okay, anything else?
then,
Do you think this is
transtubular potassium gradient
yes, we
also
are
we
come
can-
to the last 10 minutes. I'm asking now directly leading question. First to the PGs and then to the experts. Is it Addison disease? Which can explain
aldosterone level will be low.
all the things from
Of
beginning.
course.
And
Yeah,
which
it could be
It
possible.
can
Yeah.
be Addison.
what is not
But
fitting in this?
potassium is not in favor of Addison.
Yes. So let's see. We had what experts, Sagar and Nikhil. What do you think?
I think this child has got a vasculitis, probably SLE form of a vasculitis.
Nene,
That has you.
okay. Before Nene, what at this stage is it Addison disease or not?
No. Addison's usually has got a hyperkalemia, hyponatremia.
Hyperkalemia.
Okay.
So
Nikhil?
the address.
What is more, if you think of it, would be hyperaldosteronism, which is causing the potassium loss, will cause an hypokalemia. So hyperaldosteronism will explain your hypokalemia and this thing. But I won't consider it to be an Addison's disease. What I think is there is a multiple system. What we need to do is we need to think.
Now, okay, for now we are thinking about Addison. Which investigations will, because we are end of the session. Which investigations you really want at this stage?
We'll do the
Pages.
We can go for aldosterone level.
Okay, so let's see what the reports have come. Yeah, let's see. So cortisol has come 5.4 at 8 a.m. Normal range is at 8 a.m. is so serum cortisol was low. This was after actually 5 days of stopping your methylprednisolone. Renin has come high, 55.2. These are the so many things are here. And let's see, you're talking about aldosterone also. Aldosterone actually on a lower side of actually, to be very frank on. Because if you this thing is upright because they have to be. So what? How do you interpret now? Now you have all reports.
So it is more like hyperreninemic hypoaldosteronism.
Yes. No. Whether all these investigations point towards Addison's disease.
I think we should have done the ACTH level also.
That
might have.
Yes. Okay. So this child can be explained because sometimes what happens is other tubulopathies are there, as Sagar and Nikhil has already stated. This child Addison's can have a rare presentation like with hypokalemia also. You can have this kind of presentation, and these are multiple case reports are there. So this is Addison's disease with hypokalemia, and hypokalemia can be explained with so many things. As you said, tubulopathy can be there, can be like gentleman kind of syndrome can be there without hypertension. Yes, so it is possibility. At this stage, any other investigation you want now?
ANA.
I think immunoblot ANA might have given.
ANA.
Yeah. So whether it is, I feel that it might be a SLE or might be some form of a vasculitis. Yeah, which has evolved over
so we have come to now this stage. ANA has come like this, and this is SMRNP has come very strongly positive. This is 104. What we call as a Sharp syndrome or MCTD. There is a mix, and other things were also there. Means if you get this kind of picture, SSA and strong 112 and RO52 things are also 120. So it is so to be cut short the story, this was a case of MC, mixed connective tissue disorder. And if you see here, mixed connective tissue disorders can have presentation like fulminant myocarditis. So that can be explained on that. Whether our Addison's can explain on this? Yes. Addison's also can be there as a part of mixed connective tissues. So now if you see here, there are a lot of reports. I just got the recent ones. This is a child with mixed connective tissue disorder, which has led to Addison's. And because of that, hypokalemia can be explained because of food intake, vomiting, contraction, as Sagar has really pointed out, like contraction alkalosis was there. Myocarditis yes, maybe presentation of acute exacerbation of mixed connective tissue disorder, which is usually triggered by viral infections, especially adeno, but we have also tried to get adeno PCR, but it was negative. So there cannot be so many diseases in one patient. So one disease process which explains all, and this usually is a mixed connective tissue disorder, MTCT called as Sharp syndrome, was put on steroid for 2 months. Activity is better now, no fatigue. Child has gained 3 kg weight in first month and 3 kg weight in next month. But pulmonary hypertension remains same. PA pressures are 34 now. And CBC is not, last CBC, last visit was 5,400, 2,34,000 count, and ESR is 80. So just opinion from experts now. So what were the problems at this case, and how one can approach such kind of cases? First, we'll go from Sagar, and then we'll go to Nikhil as your concluding remarks.
Yeah, I think initially always think of infection etiology first, which we rule out tuberculosis, that is a common in India. And then we come to the more of a inflammatory or autoimmune disorder. The disease pathology can be variable in various time, that it may involve the heart, liver, all organ I think is involved. Brain is involved, heart involved, lung is involved, blood is then liver is involved. So all organ are involved, and usually it become reversible when you put them on the immunosuppressive or the immunomodulatory therapy. One point also I want to mention is that there was the dengue was positive, then there was the Wilflix was positive, COVID antibody was positive. Some in autoimmune disease, the antibody may come positive and may not be truly the disease. So we have seen in the COVID that COVID antibody positive and all the tests all are positive, all antibodies are positive. So you should not consider only antibody positive as a disease. So,
okay, Nikhil.
So we had some red flags from the beginning. We had polycirrhosis, which was there. There was some thrombocytopenia, which was there. There was renal involvement. So it was initially pointing out to a multi-system disorder. So anytime you see a patient, think in a broader thing, think of a disease which will involve a single diagnosis, which will involve all of them. So initial reports, initial few slides also pointed out that there was something in the as connective tissue disorder, adolescent female having polycirrhosis, anemia, muscle weakness, even renal involvement. We would have thought it has to be an SLE. So my clinical diagnosis would have been SLE, and the acute phase could have been it could have been a macrophage activated syndrome in an SLE. So my primary clinical diagnosis would have been but it turned out to be a little bit different thing. But again, the message home would be that we need to think in a broader spectrum, think of a single diagnosis which can explain everything.
Yes, yes. So just to summarize, what were the problems in this case? This girl was just investigated for a long time, and so many investigations were done. Problem is that Addison's was the first possibility for me, but problem was Addison's usually, as both our experts says, usually has to be hyponatremia and hyperkalemia. This presentation was not a classical one because of other associated things, maybe renal involvement, maybe her poor intake, maybe vomiting, and so many things, hypokalemia. It was one problem for us. Then second problem was getting the sudden acute onset congestive cardiac failure, which was very difficult to say. And more of top of that pulmonary hypertension was not explainable with that congestive cardiac failure or cardiogenic shock. That was quite surprising for me at this stage. So that's from that point onwards, we started thinking of this thing. So weight loss and all that, not necessarily always, because so many markers are there, and so many, and all this vitamin D, calcium can be contributed to the nutrition part. In fact, hypokalemia also can be contributed to the nutrition part. Once the patient come from the acute illness, and as Nikhil has pointed out on day one, again, her metabolic things has reverted to the same thing, what it was a pre-illness kind of thing. So whenever you get this kind of things, you try to come to a conclusion why these things are not behaving at per expected things. So my first concern was Addison. And during the course of Addison's diagnosis, when we come to as ANA was, now it is previously ANA, actually to be very frank, I have had it. ANA by spot test was negative at very beginning. So I purposefully avoided that thing because it has come, it can come also. Immunofluorescent test can come negative initially also. So you have to go for a proper ELISA method, and now different high good techniques are there. What is called as blot 18. So in that only you can find out. Otherwise, routine spot test which are done in routine laboratories will come this AN is negative. Never try to do all this investigation when child is in crisis. So try to do all these investigations when the child settles down. Otherwise, again, erroneous reports are there. So this particular case tells us you have to have a very broader kind of view towards the case. Try to manage the acute problem, life-threatening problem. Don't go behind diagnosing the things in acute crisis. Try to settle the things, and once you settle, try to keep the bigger possibilities and go on investigating and what particular type. As Nikhil really pointed out, both experts pointed out, okay, you cannot have too many diagnoses: dengue, well flix, rickettsia, and then COVID, and so you have to have one diagnosis which can explain that vaccine and waning of these diseases there over a period of time. And so that now we have to follow this case, we have to think possibility of treating that pulmonary hypertension with different disorders, whether other immunosuppressive drugs are required or not, we have to think. So first, thank you very much, PG students. You have really done great job. You are pointing towards really good things. And as usual, my experts and good friends, Dr. Sagar and Nikhil, they have really taken us to the final diagnosis. I'd like to thank Ram Gopal sir for giving me this opportunity to present this quite interesting. This was a quite challenging case, to be very frank, to manage it, because some point of time it is very difficult to whether to intubate or not, how much potassium to give, why this sodium, and if you see all kinds of electrolyte and ABG disturbances we have seen throughout the case. So it is very difficult to pinpoint at this stage. And Bhavesh sir is not there, I think. He is also one of the brain behind this starting this, and I want to congratulate Dr. Sushma madam for mentoring PG students to come to a really good diagnosis. So thank you, one, and from at least from this month I will sign off from Facebook Live. Maybe next month again we'll meet with some interesting case with different teams, different PG students, and different experts. So thank you very much. And over mic to Ram Gopal sir. Yes.
Thank you, sir,
Thank you.
for the
Thank
interesting
you.
case.
Yes,
One most important thing, the link was posted at 6 o'clock. It was a very last moment. Plus, the vacation period is going on, but still we had a more than 250 delegates. So that shows the success of your programs. So
Yes, sir.
thank you to Vinayak sir.
Thank
He has
you.
taken a lot of efforts.
Yes.
And on 6th, again, we would be having pictorial pediatrics. Sorry, on 8th.
8th.
Yeah. So again, two interesting topic. One would be the sleep pattern videos by Dr. Indu Khosla, and X-rays, Dr. Ravi. So we'll see on 8th. Till
Yes.
then, good night.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank
Thank
you very
you.
Thank you so much.
Nikhil,
Thank
and thank
you.
you, Sagar.
Thank you.
Thank you.
Yeah.
Thank you, sir. Thank you.
Sir, करू